Hi guys, so this is the review video for the osteoporosis case for physiology. So what I'm going to do in the first video is run through the mastery questions, and I'll emphasize some of the points that I thought were of some difficulty or some rough spots I thought that I detected as we did the small group session as I go. And then and I'll emphasize some answers to questions that I've gotten through the email. And then in the second video, I'll go through the quote physiology type material that we covered in the session itself. So that'll be mostly question 3 and 4 in the concept map, but we'll go through that. All right. So first of all, just a reminder, my office hours for this block are on Fridays. And unfortunately, on March 30th, I will not be there because it's Good Friday and I'll be traveling. I'll be with family for Easter. However, next, and I won't be there Sunday either at this address, although I usually am, so you can get me weekly from 10 to noon if you just click on that link. And it should be fairly easy. Having said that, I am certainly available to meet with you next week if you want to come and ask questions or review with me before your formative quiz. And of course, I'll be available a week from Friday, the 30th, a week after that for sure, and then next Sunday as well, okay? So I'm available by appointment. Don't hesitate to make an appointment. The one thing I don't want to see is a student that's not doing well, that didn't actually come see me or didn't come talk to me. I think that I'd like to see you come and get help if you need it. You guys know the rest of this. The old test questions for this material, I will email the class and let you know where to find those. There won't be hundreds or anything like that, but there'll be at least 7 or 8, I think, good sample type questions of the types of things that you may see on the exam. And just to let you know, the Synapse lecture has a bunch of old exam questions, some of which you've seen before at the end of that. And then I will also email out skeletal muscle physiology questions, practice questions, probably only 4 or 5 of those that you can go through. I did not get those at the end of that lecture either, so I'll give you that file. All right, just so you know where to find it. All right, so our first mastery question: what does vitamin D? What effect does vitamin D have upon the regulation of bone processing? There were a lot of questions about this in the class, probably because it addressed the one readiness assessment question that I had. What vitamin D does in it actually acts on the parathyroid, not the bone directly. And what it does is it allows the parathyroid to correctly detect calcium in the plasma. So if there's no vitamin D, your parathyroid thinks that the calcium in the plasma is low, even though it's not. And when it thinks the calcium's low, its response is to release PTH. And PTH will break down bone inappropriately. And this would be a form of hyperparathyroidism. So you should probably be aware that that is an effect. Now, having said that, the major effect of vitamin D, and I did emphasize this in the session, is upon the gut. And that should be the first thing you think about when you think vitamin D deficiency. The fact that vitamin D is necessary to increase absorption of calcium and phosphate. All right? So vitamin D, even though it says it's acting here, what it's really doing is it's acting to allow the parathyroids to appropriately regulate PTH. Okay, a pharmaceutical rep is trying to sell you a new drug for osteoporosis with the aging population. This probably is not an unrealistic concept. And basically it wants to know, okay, what do you think the possible mechanisms might be? So I'm really pointing you to these regulators of bone formation. And I did say assuming that it's affecting bone formation. Just a quick review of how bone is formed. We have these vesicles that are pinched off from the osteoblasts, and what happens in those vesicles, and this is really the first step, is they have collagen inside them. Most of it is collagen type 1 in contrast to what you see here. And what happens is calcium phosphate precipitates upon the calcium to make hydroxyapatite within the vesicle. And it makes what are called hydroxyapatite models, okay? What I mean by that is the hydroxyapatite that is formed here, the little bit, is extruded through the membrane out into the matrix. And once it hits the matrix, that more calcium phosphate and more collagen forms around it. It's sort of like a nidus for precipitation, or that's the way I think of it, for those of you who remember your chemistry. So this is what's called a hydroxyapatite model, and it's extruded across the membrane, and then this preformed model actually serves as sort of a substrate upon which further precipitation and further hydroxyapatite formation can take place in the matrix, okay? So it's a two-step process. The reason why that's important is because of the way that it's regulated. So the first thing to notice, pyrophosphate, two inorganic phosphates hooked together, inhibits matrix mineralization, okay? So TNAP, which is tissue non-specific alkaline phosphatase, increases mineralization, and the reason is because that hydrolyzes PPI to just regular inorganic phosphate. So it turns pyrophosphate into inorganic phosphate, and that provides more substrate for calcium phosphate precipitation. So increased TNAP activity, increased calcium phosphate precipitation, increased bone formation in the matrix, okay? NPP1 decreases mineralization, and that's because it converts ATP to ADP and pyrophosphate. So it increases the pyrophosphate, that inhibits the mineralization reactions, okay? The tricky one is ANK. And it actually increases mineralization. And what it does is it passes pyrophosphate through a channel from the vesicle lumen into the matrix. Okay? So you might think, okay, I'm reducing pyrophosphate in the vesicle lumen, and that will increase model formation, hydroxyapatite model formation in that vesicle, but I'm also increasing pyrophosphate in the matrix, and I would think that that would inhibit bone formation. So the question is, which one wins? You have an increase here and a decrease here. And the answer is the increase in the vesicle lumen wins. And the net effect is to increase bone formation when you increase ANK activity. The reason is because you're taking pyrophosphate out of this vesicle lumen. Well, this is a really small volume relative to the matrix. So you take 1,000 pyrophosphate molecules out of that lumen, you're going to decrease the pyrophosphate concentration in that lumen quite a bit. You add that same 1,000 out here in the matrix, which is a huge volume, it doesn't really make that much difference to the pyrophosphate concentration because the volume is so big. Okay, so the effect of changing the pyrophosphate concentration is much more dramatic in the vesicle lumen because of the smaller volume. You can remove the same amount here and add it here. You'll get a big concentration drop here and not that big of an increase here. So you increase model formation on balance, and that increases bone formation. Osteopontin decreases mineralization. It actually binds calcium, and it can be phosphorylated, and that actually increases the negative charge and causes it to bind even more calcium. So that decreases mineralization. And bone sialoprotein is part of the matrix that increases calcium phosphate precipitation, and so that increases mineralization. Okay. So osteopontin decreases mineralization, bone sialoprotein, BSP, increases it, okay? So those were our targets. A 62-year-old woman visits her family doctor with complaints of chronic lower back pain, okay? So I'm going to I asked you to identify which factors here are associated with a diagnosis of osteoporosis. Osteoporosis classically is, of course, the result of a reduced estrogen, okay? And that leads to increased bone resorption. So the fact that she's 62 and probably postmenopausal, that's your first major clue, okay? And the first thing that I want you to notice is that when you see osteoporosis, the serum calcium phosphate and alkaline phosphatase, basically the serum values are all normal, despite the fact that you're breaking down too much bone. Presumably, that is because of the gradual nature of the disease and the fact that you don't really build enough calcium to make a difference over time because it's so slow. One lesson to take away from here is don't just look at serum calcium and think you can predict bone density, and don't look at bone density and think you can predict serum calcium, because you can't. It's going to depend upon the disease, and in particular because osteoporosis is so common, you need to recognize the fact that your clin path values are going to look pretty normal despite the fact that your patient probably has osteoporosis. Other things that contribute to this clinically, the physical inactivity is going to reduce the modeling of bone, and it's just a natural physiological reaction which would make the bone thinner because you're not putting as much stress on it. She has a family history of osteoporosis, and the treatment of osteoarthritis with a corticosteroids may lead to hypercortisolism. So we didn't talk about this a lot in the lecture, but notice that glucocorticoids do increase bone breakdown. So one thing you'll notice about glucocorticoids, they're kind of a special case. We're not really covering the mechanism in any depth, but most of these things cause increased bone breakdown. At the same time, they increase bone turnover. So for instance, PTH is a classic. You increase osteoclastic activity, and you also increase osteoblastic activity. And what happens is you increase this more, and so the net effect is to break down bone, right? Notice glucocorticoids don't act like that. They actually increase osteoclastic activity and decrease osteoblastic activity. So they're an exception to that rule. Thyroid hormone I really didn't cover, but it was in the case. Hyperthyroidism does it the way that PTH does it. We'll talk about growth hormone in the growth and development section. And estrogen we just talked about. The fact that you reduce estrogen, both of these increase. But because of the effect on apoptosis of osteoclasts and osteoblasts, your osteoclasts survive longer, your osteoblasts don't survive as long. So both of these increase, but on balance, osteoclastic activity increases more. So that's a little bit more like PTH in that respect, okay? Below is a diagram from the lecture, why does urinary calcium increase after an initial decrease? So first of all, please note, although I can't honestly remember whether a question over this diagram appears on the formative or not, questions over this diagram have been known to appear on exams before. There'll be a practice exam question over it as well. So do note that you should be familiar with what's going on in this figure, okay? So let's take a look at it. First thing to note, this is a normal patient, okay? So it's probably a dog or something, right? And what they did was they just injected PTH and looked for the effects of PTH upon urinary values, but you can infer serum calcium and phosphate values from this as well. The first thing to notice, we're adding PTH here at this blue line, and we are taking it away here at this blue line, okay? And this is time in days, all right? So what happens first is serum calcium rises. In response to adding PTH, serum phosphate falls, and you should expect that, okay? PTH causes more bone breakdown. It causes you to urinate more phosphate and urinate less calcium, and that will cause you to decrease the phosphate and increase the calcium, and then you have the effect upon active vitamin D, which will increase the calcium as well. You increase the, you allow the kidney to make more active, the active form, the 125 form of vitamin D. If we look at urinary calcium, we get this initial drop. And that is the direct effect upon reabsorption of calcium from the tubular lumen back into the body. So the way the kidney works, you filter plasma, and the plasma goes into the kidney tubular lumen, and then what happens is your kidneys take the stuff back out and put it back into the body, the stuff that it wants to keep. And it leaves the waste products and they become urine. Okay, so you're taking calcium and phosphate out of that tubular solution, and you're putting it back into the body. And what PTH does is it increases the rate at which you resorb calcium, because you want to raise your calcium concentration in your serum. And so you immediately in the urine see a drop in calcium. Okay? And then what happens is the calcium gradually rises here. And the reason is because the serum calcium is gradually rising. So as you filter that plasma into the tubular lumen, you're actually filtering more and more calcium because there's more and more calcium in the serum. And so what you do is you exceed the ability of, what you do is you add calcium, so much calcium to the tubular lumen that despite the fact that you've reduced the resorption rate, you're increasing the calcium in the urine anyway, okay? And so you get a gradual increase as you break down more and more bone, and as you increase calcium and you make more and more vitamin D maybe over a period of days, and that increases the calcium. You increase the serum calcium, that increases the filtered calcium, and your urinary calcium gradually increases despite the fact that you have reduced the resorption. You've just added so much calcium to the tubular lumen that the urinary calcium goes up anyway, okay? And so you'll notice the hydroxyproline, there's the effect on intestinal absorption and bone, okay? And that's over hours to days. And the hydroxyproline goes up because you're breaking down more and more bone, and that's a byproduct of collagen matrix degradation. Your tubular reabsorption of phosphate actually drops and then rises again. And what that means is that you've got more and more phosphorus in the urine. That's basically what that tells you. The PTH will reduce reabsorption of phosphate, so you'll have more and more phosphate in the urine. And then that reabsorption will gradually rise again as you increase the phosphate more and more over time, all right? You can actually see the phosphate eventually starts to rise as you break down the bone and you increase the reabsorption and all that, all right? And that causes the increase in phosphorus for the same reason your calcium increases, okay? All right. Body regulates serum calcium. What will happen to serum PTH and calcitonin when the serum calcium goes down? So this figure caused some confusion amongst some of you. Plasma calcium is your stimulus, and then the y-axis is your release of hormone, or the concentration of hormone, and that of course is higher when you increase the release. So the lower the calcium, the higher the PTH release in response to that, and an effort to bring your calcium back up toward normal. And so at very low calciums, you have high PTH release because your body's trying to get the calcium back up to normal, and that leads to a high PTH concentration, okay? At high calciums, your body's trying to get the calcium back down to normal, and calcitonin will be high because that will tend to reduce your calcium back toward normal. Okay, so this is the stimulus, high calcium. This is the high calcitonin concentration you get in response to that because you've increased calcitonin release. Okay, so that's what the bottom line is for this figure. Decreased calcium, serum calcium, increased PTH, and decreased calcitonin. And that has effect on bone, intestines, and kidney, and that will those will combine to try to get your calcium back up toward normal. Okay. All right. Diseases in which organs could result in vitamin D deficiency. So this is the process by which active vitamin D is made. And you will notice that it involves the skin, if we're talking about sunlight. It involves the liver, which converts vitamin D to 25-hydroxy vitamin D. And it involves the kidney, which converts that to active vitamin D, or this 24-25 inactive form if you have an excess of vitamin D and you just want to urinate it out. So diseases in any of these three organs can cause signs of vitamin D deficiency, which is why we make you learn this pathway and learn the organs involved. In particular, pay attention to the fact that the kidney is involved. We've got renal coming up in August, and you will see signs of vitamin D deficiency with renal disease. Okay? So, that is it for the mastery questions, and now I'm going to record video 2, and we'll go over the relevant questions from the small group session. Thanks.